Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure of moderating today's tumor board. We have a very esteemed panel of individuals today with us, and so I'm going to ask them to each introduce themselves.
Hi, I'm Norman Womark. I've been around for a good many years, as perhaps some of you know. I'm chairman of the NSABP Foundation and one of the chairs for NRG Oncology and the contact PI for that group. And I'm professor of surgery at the University of Pittsburgh.
Hi, I'm Tom Buchholz. I'm a breast cancer radiation oncologist. I'm the medical director of Scripps MD Anderson Cancer Center and professor emeritus at MD Anderson Cancer Center in Houston.
Hi there, I'm Sarah Hurvitz. I'm at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. I'm professor of medicine and director of the breast oncology program there.
Hi, I'm not going to tell anybody how long I've been around, but I am the director of imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am primarily a breast imager, but I also do PET imaging as well. So if I come on a PET scan, it does come with a little bit of experience in the background. I am a member at Memorial, which is the equivalent of a professor, and a professor at Cornell Weill as well.
Thank you so much to all of you for joining us today. I look forward to learning from each of you. This is an older patient, a 78-year-old Asian American female with a prior history of stage 2A invasive cancer, ER/PR positive, HER2 negative, who is on adjuvant anastrozole, so sort of currently receiving adjuvant endocrine therapy. And she experiences a recurrence that is ER/PR positive, HER2 negative 8 years later, and has metastasis to the bone and liver. So we're going to discuss, among other things, her treatment options. And of note, the patient really has a strong desire to try to avoid intravenous chemotherapy. So we want to keep that in mind when we're thinking about this particular patient today. So a few more details about her care. In 2011, she underwent bilateral mastectomy with sentinel lymph node biopsy. At that time, she was found to have a 1.8 centimeter grade 2 invasive ductal carcinoma with lymphovascular invasion and micrometastasis in 2 sentinel lymph nodes. She subsequently received adjuvant docetaxel and cyclophosphamide for 4 cycles, followed by adjuvant radiation therapy. She then received adjuvant anastrozole and has been compliant with that for 8 years when she was found to have an elevated CA27-29 level, which prompted additional evaluation. She is asymptomatic at this time and has an ECOG performance status of 0. Of note, her medical history includes coronary artery disease, type 2 diabetes, hypertension, and hyperlipidemia, though all of these are currently under good control. The prior bilateral mastectomy, as we mentioned, at this time she is postmenopausal, she's a non-smoker, and has an unknown family history. And so I'll ask Dr. Jonkelson if you wouldn't mind walking us through some of her imaging in terms of her systemic staging scans.
Okay, so this was the only image that I was provided for this particular patient, but really shows the salient problem in that she has a liver metastasis in the posterior right lobe. Apparently, she also had bone metastases. Clearly, she needs a biopsy of that liver lesion.
So a liver biopsy confirmed the presence of metastatic carcinoma consistent with breast cancer with neuroendocrine features. Positive chromogranin and synaptophysin. ER was 90 to 100%, PR 40 to 50%. HER2 was 1+, negative with a Ki67 of 15%. PD-L1 is unknown. She had previous genetic testing in 2012 in which she was found to be negative for both BRCA1 and BRCA2, but 2 variants of undetermined significance you can see there, and she has not yet started treatment. So let's start out with Dr. Hurvitz, if you might comment on how you might approach this patient, and if you might comment about the neuroendocrine features, if that has any bearing on your decision about systemic therapy.
Yeah, so there are a couple of interesting points to make about this particular situation. First of all, she was on prolonged adjuvant aromatase inhibitor for 8 years. And right now, in a patient like this, we don't have solid, consistent data telling us that the use of beyond 5 years of an AI in the adjuvant setting is significantly improving outcomes for patients. We have a number of trials looking at use of AIs beyond 5 years. And there was even a very nice EBC-TCG meta-analysis presented a couple years ago at San Antonio that suggests there may be benefit with prolonged therapy. However, that benefit seems to be restricted to patients who started with tamoxifen and switched to an AI, and possibly lymph node positive disease. So it's a discussion. There are some patients who are tolerating the AI very well. She did have 2 positive nodes. I think it was reasonable for her to continue beyond that 5 years. I'm just making the point that we have data that we need to follow out for long-term outcomes to help us know better whether or not a patient would be suitable or is likely to benefit from prolonged endocrine therapy. The other point is the use of surveillance tumor markers. She was having CA2729 followed. And again, this is something that a lot of clinicians are doing in clinical practice, but we don't have really good evidence that catching a metastatic recurrence at point A versus point B is improving a patient's long-term outcome. In other words, not waiting for the disease to be symptomatic. So right now, it's not supportive to do this sort of surveillance tumor markers or scans in a patient who's feeling well. That said, a lot of clinicians are doing it. And in this particular situation, it did pick up that she had a distant metastatic recurrence. She, in my opinion, this is a non-controversial discussion and decision to make. She's a very healthy, in terms of performance status, 78-year-old with a frontline situation, ER-positive metastatic breast cancer involving bone and liver. It occurred on an AI, so I would start her on fulvestrant combined with a CDK4/6 inhibitor. And in this particular situation, my choice of CDK4/6 inhibitor would be ribociclib. The reason is that the MONALEESA-3 clinical trial, which evaluated ribo plus fulvestrant in postmenopausal women in the first-line or second-line setting, demonstrated not only a significant improvement in progression-free survival, but also in overall survival. So it's the only doublet regimen that has demonstrated overall survival in this particular situation. That said, the 3 CDK4/6 inhibitors all appear to have very similar PFS benefits. It's just that only 2 of them to date have emerged with overall survival benefit, and this would be my choice at this point for her. The neuroendocrine features don't really change the way I think about this. All of the CDK4/6 inhibitor clinical trials have published very detailed forest plot analyses looking at different tumor subtypes, PIK3CA mutation, PR expression, area of world, et cetera, as well as genetic factors. There's not any histologic marker that's been looked at or biological factor that's been looked at or patient characteristic that predicts for benefit or lack of benefit with these drugs.
Perfect. Thank you. And if I can just ask, in the era of this, ongoing pandemic and the absence of widespread vaccination, at least as of yet, would you ever have a consideration, just considering the increased toxicity of the CDK4/6 inhibitor, would you consider fulvestrant alone, or would you absolutely, because of the survival advantage that you mentioned, want to incorporate the CDK4/6 inhibitor?
If she were a 78-year-old woman who is not as healthy, not able to come into clinic for visits, for blood counts and EKGs and close monitoring, ECOG performance status closer to 2, then I think single agent endocrine therapy would make sense. But this woman is otherwise very vigorous sounding in spite of having some comorbidities, and she does have liver metastases. And when you have a regimen, this doublet regimen associated with an overall survival benefit, I think it's best to give her the best odds of a prolonged survival. Very careful monitoring is warranted, and the patient's going to have to be educated on, reporting any fevers, et cetera, due to the grade 3/4 neutropenia associated with CDK4/6 inhibitors. We're increasing our use of home health visits for blood draws and even EKGs now. And the drug makers have made this available to some patients. So that is helping some of our patients in combination with video visits with physicians and nurse practitioners to make sure that the patient's tolerating therapy well.
Perfect. And I think that that's, would help her achieve her goals of avoiding intravenous therapy and while also, as you mentioned, achieving survival advantage and an excellent chance of response. So I think that achieves all of our objectives.